I was a graduate fellow in health policy research at the Heritage Foundation last summer, and my white paper focused predominantly on direct primary care. The vast majority of which Dr. Josh touched on this morning. He really covered the who, what, and why of direct primary care. So I'm going to focus more on the how from a policy perspective and just kind of introduce some ideas that have been getting tossed around on the Hill and back in your home states to try and lift the restraints that are currently prohibiting these kinds of practices from flourishing. So right now in the States, how long do we have? It's like 5 minutes, 10 minutes? Yeah. Okay. Okay, so I'll go quickly. Right now in the States, there's a question about how these practices should be entertained. Basically, if you pay a monthly service for something healthcare related, most people look at that and just assume it's insurance, but there's a distinct difference between these practices because they shouldn't really be treated as risk-bearing entities. If you look at what their services they're offering compared to the money they're taking in, it's a completely different model from insurance, but for legal purposes, it's still important to make that distinction. And that is one that we've had some success with on a state-to-state basis over the past several years. When I say we, I mean direct primary care physicians. Most recently, talking to Dr. Gross yesterday, he said Mississippi recently passed legislation, so I think now it's up around 10 or so states that have distinct language saying that's good. On the federal level, there's a lot of frustrating legal mumbo-jumbo that's getting in the way of these. So a little known exception in the ACA, everyone here read the ACA, right? Yeah. So I read a portion of it, and there's a little known exception that says direct primary care medical homes are allowed if they're to be sold on exchanges if they're given in addition to a wraparound insurance plan. So basically, real quickly what that is, under the ACA, there's 10 categories of health that have to be insured by every insurance plan. One of those is primary care. Basically what the ACA says in this exception is if you're enrolled in direct primary care, you can have an insurance plan that only covers the other 9 things, which significantly brings down the cost of insurance, and maybe even more so to offset the cost of your enrollment in direct primary care. The sticky thing with that is that they use the term direct primary care medical home just to put that Obama spin on it, and they distinctly say that the Secretary of Health and Human Services is responsible for defining the terms that direct primary care physicians must meet to qualify as a direct primary care medical home. HHS hasn't done so, and they've given no indication as to when they will do so, so they've effectively put a halt on that just by passively doing nothing. Second obstacle on a federal level is how these are dealt with in conjunction with HSAs. If you think about direct primary care, the most common sense way to pay for it is through an HSA. But there's part of the IRS tax code says if you have an insurance plan and a high deductible insurance plan, you can't couple it with an HSA. Well, the way they would treat direct primary care is as it makes most sense to have a high deductible insurance plan in conjunction with an HSA if you're enrolled in direct primary care. So it's on the federal level, it's similar to what we dealt with on the states, is that they have to distinguish between insurance plan and direct primary care. And one way this is tried to be addressed is Senator Orrin Hatch from Utah. I'm sure some of you are familiar with him. He proposed the Family and Retirement Health Investment Act of 2013, and the language, I'll quote here, says, periodic fees paid to primary care physician count as qualified medical care for HSAs. So he's saying you not only can't count it as insurance, but it actually can be paid for through an HSA. So that bill is, of course, stuck in committee. Another proposal or concern is how to deal with these for Medicare patients. The question will always be, oh, $600 a year, some people can't even pay that, and that's a fair question. So there are proposals for how to reimburse through the government. So Medicare currently has a plan by Bill Cassidy from Louisiana to say Medicare can pay $100 a month or $125 for dual eligibles, which are people who have Medicare and Medicaid, into a direct pay type practice. And if you look at the cost benefit savings, that would actually save the government money in the long run and improve healthcare. So of course that bill died in committee. And then another issue with Medicaid that you could consider is block grant HSA funding, and then the states could save any money off the top that they get from the improved benefits of having direct primary care. I think Utah and Tennessee were looking at proposing those sorts of things, but as we learned yesterday, it's really difficult to get these proposals through CMS. And so really quickly, I'll just close by saying that there's just this quote from one direct primary care doc, because we're gonna have to defend this model to other people who think that it's dirty and making profit is bad. So I found this quote from a direct primary care doc out in Maryland, and he just said, we have to remember, money is not purified by first passing through an insurance company. So I just wanted to cover those ideas really quickly. Hopefully I didn't go too fast, and hopefully I left some time for questions.
You have time for questions.
I have time for questions. Was that too fast? Did any of that make sense?
That was awesome.
So the bill that was proposed, is covered, 100 or 125.
Yeah.
Then would it also have an anti-deductible plan?
So the idea is that it would be in addition to the current Medicare, Medicaid coverage, but because the savings of it, the savings for people enrolled in direct primary care, we found one study published in the American Journal of Managed Care, so that's a peer-reviewed journal, and it found that the savings per patient was over $2,500 a year when it only costs $1,500 a year to be enrolled in that particular plan. So the idea is that CMS would save money in the long run. I hate to say spend money to save money, but that's the sort of idea. And actually, Representative Alan Grayson from Florida has reintroduced that idea since then, but I don't see it going anywhere anytime soon.
I don't know if you know off the top of your head, but you said there was 9 other things that had to be covered by wraparound and direct primary care by ACA. Do you know what those 9 things are?
I don't offhand. They've been in the media. It's primary care, hospitalization, psychiatric. The controversial one is like gynecology. It's if you named the 10 main categories of healthcare, it'd probably be those.
And you can Google 10 essential benefits for ACA, and it will come up on that.
So what is the current status? I don't know if maybe I got too absorbed in it. What is the current status? Can you have direct primary care count as a qualified, for the ACA purposes, a qualified plan? Can you get fined by doing direct primary care?
By doing direct primary care, can you get fined for it?
Right, because ACA fines you if you don't have a qualified insurance plan, right? Or a tax, sorry.
Right. So yeah, I don't think anyone actually knows. I think the big hold right now is that insurers who want to sell these wraparound plans on the marketplace so they would qualify, they can't even do so. So if you have off-market insurance, then you would probably still be subject to a fine.
Can you explain a little bit more why these insurance companies cannot put these wraparound plans onto the marketplace?
Because the Secretary of Health and Human Services has to outline rules for what qualifies as a direct primary care medical home, which is basically, it's direct primary care that meets their standards, which most would be, if you look at patient-centered medical homes, most of them give far inferior care to direct primary care practices, so its qualifications would be met by most practices without problem. But the idea is that to be exempt from insurance providing the primary care portion, the direct primary care practices would have to qualify as a direct primary care medical home under guidelines given by the HHS, which haven't been given. Does that clear it up?
My question is, so you have to say, for an insurance company, or for you to get insurance, you have to be covered by those 10 essential items.
Yep.
But the exemption is, if you are under this medical home, you're only required to have 9 essential items in this wraparound policy. If we don't have a definition for what direct primary care is, can insurance companies even elicit for the ones that already do enroll in this direct primary care to have a wraparound policy that only does 9, because that doesn't necessarily fulfill the requirements for the marketplace?
Yeah, I think they can, and there are two companies at the time of my publication that were trying to do that, and we're having mild success with it.
But you don't have to purchase through the marketplace to have your plan be a plan that satisfies the ACA.
I have a general question. So the marketplace, so I have the experience of being in a position where I worked and I'm married, and so my wife wasn't working, she was in school, but her school's premium was really expensive, and my insurance was going to cost a lot of money to insure both of us as opposed to just myself. So this is before the marketplace went live. There were still services where you could type eSurance, where you could type in, I can't remember what it's called. You could just fill out an application essentially, and then you could get private insurance. And it was essentially the marketplace. I don't know if anybody's familiar with this. This is before, and so we just bought it because it was cheaper to insure that way instead of both of us under. Anyway. So what is unique about the marketplace is something I've never understood.
It's that's probably one you could answer better than me.
So, and by the way, that's been fine.
Yeah.
Okay. So I like to call them the government health insurance exchanges rather than marketplaces. And we have government health insurance exchanges, and there are also private health insurance exchanges, which are starting to, we're seeing more and more of them. And hopefully having these government health insurance exchanges won't kill that entire segment of the industry. So, however, in order to get a subsidy through Obamacare, in order to qualify for premium support, you have to get a qualified plan through the government health insurance exchanges. But let's, catch me with all these questions because they're really important, but I want to hear from you guys, and who's the next?
How about Jaron?
Yeah. All right. Hi, I'm Jaron Smith. I am a first-year medical student at Medical College of Wisconsin. And this isn't where I want to start. There we go. And I'm going to talk about a model that was developed by Kyle, who is a second year and the current president. The year after Kate, who's a third year sitting in the back, started the Benjamin Rush Institute chapter. And first of all, I want to give a shout out to her because from what I've heard, many stories that it was a fight to get it on our campus. And so if you have any of those concerns, maybe she could be a resource for you. This is how can we get the conversation started about the values and the policies that we're sympathetic towards as members of Benjamin Rush Institute and just as future physicians. And we think that Journal Club is one potential solution depending on your individual situation on your campuses. I understand that this won't be a model for certain campuses based on student size, but see if it's just something to get your mind going. What has helped? Well, before I go into that, just tell you what it is. Every month, we have 2 student presenters, and there's Peyton Sturba in the bottom right presenting. And every month, we'll have a topic chosen by the student who will submit a proposal to the president, who was Kyle at the time. And you say, this is what I want to present on, here's the article that I want to present on, or articles, because sometimes ideas come from multiple sources. And then he'll choose if, yes, we would like you to present. And then you have that person present. Each journal club each presentation is about 20 minutes. Usually we say 10 minutes for presentation, 10 minutes for questions. It doesn't have to be in that order. You can intersperse questions throughout your presentation. It's up to the student. And I can tell you how this has helped because we've gotten about, Beth mentioned, about 50 to 60 on average. Sometimes it's less. Sometimes we get quite a few people. And here are some things that have helped us with that. Event days, time, and consistency. So it's every month. Everybody knows that Journal Club is every month. And we advertise it every month. It's not the same time of the month every month, but it's on a Wednesday every time, usually. And we plan it around exams, specifically around M1 exams, because M1s are the ones who make up 90% of the people who come. And we do it not right before exams, and sometimes we'll do it after exams or the week after exams, 2 weeks after exams, just so we can get the word out in time. It seems like consistency has really helped, especially because most organizations don't have that. They'll have, this is a networking reception, but they only do it once a year. This is a procedures fair, but again, it's only once a year. Food, you're all accustomed to this. We have an allocated budget, and Charlotte and Beth have mentioned that this is reimbursable, and so obviously to an extent. But this is something that really gets people there. And if you have enough, that's something that is a really big deal. If you don't have enough food, people get mad. And so you want to have enough food, and it's okay to spend money on food for that purpose. Science. We use Facebook. I think most medical schools have a Facebook page for your class, and so we'll post it on our class of 2018, and class of 2017. We know that 2017 really won't have much interest and won't come. Again, like I said, we'll probably get like 5, maybe 10. But that in the top right is one of our postings. So this was actually about Ebola, so not exactly a market-based paper or topic, but just in the post, I just said, do you know that in January we recorded 100 new cases of measles in the U.S. and 254 new cases in Berlin, and then I put the 2 articles that people are going to be presenting on. I do that about a week or a few days before. We also have a student digest. I don't know if you have this, where we say, hey, this is happening this week, and all the events for the week. But Facebook's really helpful, and then we encourage them to RSVP because food will be there, and our food, and I tell them how much food I order is based on how many people RSVP, and that gets a lot of people to RSVP. That's something that's really seems to be helpful. A little logistical issue with this is that sometimes the journal articles are through JAMA or New England Journal of Medicine, and you can't post that because if you post the article, or if you post the link to the article, then they have to sign in and then they have to search for it because it's through the school portal, because they purchased the rights to the journal, or at least access to the journal. So sometimes you have to download the journal article, put it on like Drive or Dropbox, and then post that, because you can't post direct PDFs onto Facebook. It's logistically kind of frustrating, but I think it's worth it because people can see, hey, I'm interested in this, or I'm not interested. And for the most part, people are interested in things like this. M1s, like I said, in first semester. If you get people going in the first semester and you get the M1s going, then they'll usually carry on at least through the end of the year, and then kind of tailors off towards the end, and then you refresh it the next year. Exploiting curriculum. I know this is at GW because I interviewed there. It might be at other places, but we have what are called pathways. You have to have non-core hours. Essentially what it is, you have a focus in your education. There's like global health, urban community health, and then there's a policy pathway at our school. There's a few others. And we tell people, if your advisor says it's okay, going to these events can count as non-core hours. And so you're using the curriculum as an opportunity. Resume builder, we tell them if you present, you can put this on your CV. And questions and crowd agitators. So incorporating questions into the journal articles, and then planting people, hopefully not in the same place, in the audience who, if nobody's asking questions, you tell them you need to ask a question. That's usually like the board members, if you have more than one, if you have a few, or just friends that you know are interested in, that will ask questions or make comments. That's something that has been helpful. AMA, we teamed up with AMA when they started this last year, namely for name recognition, leveraging the brand, as well as funding, because they have a lot of money. And as we'll see, it's also been kind of a hindrance. So pairing up with a better known organization that may be sympathetic towards BRI values, or just policy or current events may be helpful. Now, issues that we've run into, finding or begging speakers. I didn't realize it would be this difficult, but it's sometimes quite difficult. And so what we've decided to do is that we'll get them all lined up as soon as possible. The upcoming M2s or M1s right now, we'll find them, we'll tell them let's present on these days, and we'll have that so we can find time to find the other speakers. Because right now we've been struggling just to, are you interested? No, because I have a proposal due, but people are very busy right now as M1s and M2s. Obviously we don't know where they are. The article choice and the topic range, trying to decide if you want to focus on specifically what BRI is sympathetic towards, or like we had something on measles. And obviously you can put a market spin onto it. But if you can get people interested and know what BRI is and then introduce ideas, maybe you can have one article that talks about something everybody can get on board with, like vaccines, and then something that's a little more technical, but you don't want to get too technical, but you also want people to be informed, like on rewarding patient or physician value. Venue size. So this is our large auditorium. We have we have 200 students in each class, and we don't have a venue that's, like we said, 10% smaller than the people who RSVP. It just we don't have that. It's either 200 or it's like 50, and I guess 50 might work, but some of the places you can't serve food in, so that's been an issue. So it looks like, oh, we don't have many people here when it's 50, right? And then the AMA, what initially our agreement was that BRI would do food 1 month while AMA presents, and then we'd flip each month. But AMA rarely came through on their speakers, and so we'd have to find speakers last minute, and they usually ordered not enough food. That would we get 50-ish to attend, in addition to the aforementioned legacy of BRI. People know that it exists, and thanks to Kate and Kyle for Kate getting the organization started and Kyle for starting Journal Club. Student body size. It helps to get 50 when your student body is 400, I guess, M1s and M2s. Like Mayo, that's not feasible at all. And I understand that. So it helps to have a large student body. But this is still like a quarter of one of our classes, or an eighth of both classes. And to talk it up on the day of, or the day before. I put dance party here because my roommates and I in undergrad would always throw these themed dance parties, and we would talk about it like weeks leading up, just so everybody knew about it. And I think for sure that got people there because they promised that they would come. They made a verbal commitment to me, and I think that, and I employ that same thing as, an anatomy group. An anatomy group. I'll say, "Are you guys going to BRI?" They're like, "What's BRI? Are you going to Journal Club? Is that today? No, it's tomorrow. Okay, what do they do again?" So telling people, because they read Facebook posts for like, if it's longer than a line, then they're like done. And so if you can just redirect them towards that, I think that's very helpful. Your emissaries, your ambassadors. Anyway, this is kind of the template that we use. Everybody uses this at the beginning of their presentation. I can email this to you. This is just the first 3 slides. And then the presentation starts. Anyway, let me know if you want that. So now it's time for your questions. Logistics or things that have come up. Yes?
So I have one question. When you say that you have students presenting the articles, how involved is that role for them?
It consists of them finding an article, putting together a presentation, they do all that, and then what Kyle has been doing, and I'll do next year, is you meet with them beforehand, just make sure that they know what's going on. But they don't have to be BRI members or part of the BRI board. We encourage all the board members to present at one point to kind of set a precedent, but it can be anybody that's interested. That's nice because it gets people involved.
Judging from the size of that auditorium, do you usually get good discussion amongst the people who are dispersed there, or is it really more almost like a lecture as opposed to discussion? What's the dynamic usually like with that setting?
We really want a discussion. And it's,
what do you get?
What do we get? It depends on the material that's presented. We had one that was it was about the epidemiology, and it was really kind of technical on measles. That was unfortunate, and it was my fault for not talking with the presenter beforehand. But some of them, like when David presented or I presented, we got people who were very interested. And if you present on something that's a little controversial or a little, kind of pushing the envelope, people really get involved. They get fired up, and then they start going back and forth, and that's what you want. It helps that this venue has microphones, and so everybody can hear. Everybody has individual microphones in that lecture hall. And keep asking questions. Yeah.
Yeah, when you say that you try to incentivize speakers by saying that they put it on their CV,
yeah,
is that like, do you have to do something to legitimize the Journal Club to make that mean something, or like, is this just, I don't know, I'm just wondering, like, can you just throw anything on there? Like, can I go give a speech on the sidewalk and count that? Or?
And our at least how our activity transcript works at our school is it's like when you fill out AMCAS or ACOMAS, where you just fill it in yourself. You're like, drop down, what category is this, like speech or something, and then you click that. So as far as legitimizing it, I'm sure if it ever came down to it, we could say, yes, they did do this for this established organization. But it's essentially, it's a way to get people to thinking of how this can benefit them.
Yeah, when they turn in the event report, one of the things that, and we've gotten caught up with this conference, but if you put down the name of the presenter and the article that they present, we'll put it up as on the calendar. And so it will be documented on our website. Here was the day, yes, they presented, and it will even show, this is how many people were there present, involved with it. So that'll do a little bit of legitimizing as well.
Good point, yeah. We do that.
One more question, and then we.
Anybody know all these languages?
Okay, great, thank you. Thank you.
All right, hey guys, my name's Kate. I'm the aforementioned Kate. So I go to MCW, and just a little bit about me. I'm going to be presenting a paper that I did while I was a fellow at Heritage the summer after my M1 year. I also worked at Heritage for 3 years before med school. I was a policy analyst there. So if you have any questions about like anything related to working in policy, hit me up. So I also started our BRI chapter at MCW and was the president for a year. So if you have questions about that too, just find me. So my paper is called Improving Healthcare Quality in the U.S., A New Approach. So it's kind of surprising if you think about it that after decades of talking about healthcare quality, you can even get away with a title like this. How can there possibly be new approaches to quality? And actually, a lot of what I'm going to be talking about or a lot of what's in my paper is really similar to what we heard yesterday during our lunch talk, which was an absolutely fabulous outline of the problems that we're facing in healthcare with quality. The IOM defines quality as care that is safe, effective, efficient, equitable, and patient-centered. And across the country, I think we see that providers struggle with every single one of those factors. So I'm not going to walk through this slide because I think we got a really good idea of what the problem is yesterday. I just kind of want to highlight this quote, which I love. Don Berwick I don't quite love as much, but it's a great quote. Every system is perfectly designed to get the results that it gets. So I think that's important because when we're looking at these problems, it's really crucial to us to remember that they don't just exist out of nowhere. There's something that caused them. We have a healthcare system that was created by federal and state policies on healthcare, which set up incentives for every single actor in the healthcare system to behave the way they do. So if we want them to behave differently, we need to look at what is causing current behaviors and think about how we can change those factors. So my paper is on one huge factor that keeps patients from acting as consumers and keeps providers from improving on quality, and that is the third-party payment system. So as we heard yesterday, Americans with health coverage have for decades received their health plan either through an employer or a federal program. So that means that healthcare benefits are almost exclusively defined by third parties. So this means that patients are completely disconnected from the cost of their health insurance plan. They pay a very small portion of it. And up until recently, coverage has generally included very generous health benefits. So not only are patients disconnected from the cost of their health insurance, they're also disconnected from the cost of their health care. So when patients are disconnected from the cost of health care, they cannot define value as they seek out care. So value is defined, that's really small, as quality and cost. So you can't figure out the result of the equation without both factors. Sorry, I lost my place. So if patients can't seek out value, then providers have very little incentive to demonstrate that they're providing it. So that's why there's no information in the healthcare system about cost, and that's why there's no information about quality. You don't need to show that you're providing high quality care. You don't really need to take the steps and make the massive investment in quality initiatives that actually make a meaningful difference. And then what does this mean for providers competing on quality is they really don't have to do that either, right? Because patients aren't seeking out quality, they're not seeking out cost, they're not seeking out value. You don't have to work towards those goals, and you don't have to compete with others on those goals. So how do we fix this problem? We also heard a lot about this yesterday. So the solution is to replace this current financing mechanism with one that puts patients in control of decisions regarding health insurance benefits and spending on health services. So the first step to doing that is to address what Ed talked to us about yesterday, which is the tax exclusion for health insurance. So this is favored the employer-sponsored coverage system that we have, and it's a remnant of policies from World War II. It was never intended to be a permanent fixture or a guiding principle of our entire healthcare system for decades afterwards. So it's ludicrous that we would even leave this policy on the books and let this be the guiding force behind our current health coverage. So instead, what we need to do is assist working Americans in purchasing insurance through, remove the tax exclusion and replace it with a direct system of individual tax relief, which is independent of employment. So under this kind of system, patients would choose a health plan themselves, and then they would use federal assistance or other funding resources like their current employer, help from a religious institution, anyone, to purchase their health plan. So patients would not necessarily pay more for their insurance under this kind of reform. A lot of people like to say, oh, you're giving people more skin in the game, they're paying more. That's not true, as we know. It simply means that they have more control over how dollars are spent. So when patients have incentives to make cost-conscious decisions, they have incentives to seek out value. So once they have those incentives, this kind of system would encourage insurers to offer more value-based insurance designs that would drive patients toward high-quality, low-cost care. And this would in turn require providers to demonstrate satisfactory performance in both cost and quality. So we have tons of examples that this kind of system does exist. We hear from the left all the time that it won't work, but we know because we have proof. We heard a little bit about Medicare Part D yesterday. Another example is the Federal Employee Health Benefits Program. Both of these have demonstrated that Americans are capable of acting as engaged and savvy consumers in a marketplace, and they're capable of making cost-conscious decisions about insurance by themselves. So another piece of evidence we have is the emergence of consumer-directed health plans, which are a high-deductible health plan combined with an HSA. Both components are necessary for it to be called a consumer-directed health plan. So these have also shown that patients can act as cost-conscious, engaged consumers. Studies have shown that patients with CDHPs are more likely to seek out and use information on hospital quality. They're more likely to use information about healthcare and drug costs to make decisions, and it also affects their general health management. They also demonstrate less reliance on emergency room care, lower hospital admission rates, and shorter length of stay. So you can see how powerful it is just to involve patients in decisions about their care, and they make better choices. So this slide is just talking about the ACA programs that were intended to address the quality problems that we have and why they won't work. Something that you hear a lot is, well, if you don't like these programs, then you don't want to improve quality, but we know that's not true. The problem is that these programs won't improve quality because they don't change the underlying infrastructure of our health insurance system. So I guess in a nutshell, because I don't really want to get into the ACA right now, but the biggest problem is that every program in the ACA that is intended to address quality does it retrospectively. So it looks at quality metrics from years before and then makes very mild changes in how they reimburse providers based on that information. So if you're a patient, you're still going to possibly the low quality provider and your behavior is not affected at all by these programs. So a better option is to prospectively change how we reward quality and cost and overall value in the healthcare system by directing patients to those providers that are doing so. Flew through that. There's some references if you're interested in reading more. I can send this around if people are interested. And then I just added an extra slide at the end about kind of what I've learned about engaging in health policy as a med student. I think the two most important things are to identify your personal strengths, which someone mentioned earlier, and then what are your goals. So for strengths, are you a good leader? Are you really good at researching and writing? Or are you really good at public speaking? For goals, one that actually we were just talking about that I really want to highlight is getting involved with state medical societies. In Wisconsin, we're automatically members of our state medical society just by being medical students. And the House of Delegates is a democracy. So we can take those seats in our House of Delegates. We can vote on resolutions, and we can affect the policies that come out of the state society. We can also offer resolutions and put forward free market ideas. I did this my first year. It didn't end well, but maybe you guys will be more successful. So that's the end. Anyone have any questions? Yeah. Oh, thanks.
Last night in the debate, there was implicit, nobody really came out and directly spoke about it in like a constructive, argumentative format, but each side talked about quality and intrinsically how they believe it should be measured. Obviously, the primary care guys are really focused on the patient quality, and then kind of rebuttal was like, well, with Dr. Ichan or whatever, he argued that quality should be measured. Like there is quality, there's totally a science to this, and there's quality based on like outcomes in hospitals, and it really intrinsically seemed to me that you really need to figure out a way to blend those numbers both together.
Right.
What's, in your opinion, how do we measure quality, and how is quality currently measured right now?
Yeah, so that is like absolutely the hardest question to answer, so it was a great question to ask. Because on one hand, as doctors, we feel like our autonomy and our relationships with our patients are affected by all these quality metrics, and they don't really work. They affect processes of care, but they don't really improve outcomes. But on the other hand, if patients are going to make decisions about care based on quality and cost, we need to give them information about quality. So maybe that means more information that patients are actually concerned about, and I think as doctors, we would be less, or we wouldn't have these negative feelings towards showing quality or collecting information about our quality of care if we felt like it was something that was important to patients, not just bureaucrats. So I think that's a really important kind of guiding aspect is, when you're on the wards and you see nurses and doctors and residents like adhering to these quality metrics, there's so much disgruntlement. And it's because no one knows why. The purpose of doing that isn't clear. And it's because it's for bureaucracy and bureaucratic purposes. So I think when the goal is to help patients, we'll do it in the right way and in a better way, and we'll see the purpose behind it.
Thank you, Kate.
All right, guys, so my name's John Grimsley. I'm a first-year medical student at Georgetown, and I'll be mostly talking to you about kind of my time at Heritage, in particular one specific paper that was published on the Daily Signal, which was in relation to price transparency and really innovation in medicine. First, I was going to explain that I also did a lot of work on like electronic health records, mainly meaningful use, of course, the policy side of that, so that'd be meaningful use, and also ICD-10. I didn't want to spend too much time on this because it's really a problem area, and I prefer to focus on like solutions, which there at the moment aren't a whole lot in electronic medical records unless you're like Dr. Josh and completely outside of the insurance structure. But nonetheless, when you're doing rotations or I think in residency, when you have to do 40 clicks to say that you evaluated a risk fracture, you can thank meaningful use for that. So that should be a lot of fun. And if you have issues with the electronic health records, again, it's mostly meaningful use. So I want to talk to you guys about, as I said, the piece that I did for Heritage on the Daily Signal that talked about, or it was mainly framed around a talk that was given by Dr. Keith Smith at George Washington University. So if you haven't had a chance to listen to Dr. Smith give a talk, whether it's via YouTube or in person, do that. He's a great speaker. He's similar to Dr. Josh, maybe not quite as energetic, but has so much great knowledge at his fingertips and really approaches it from a surgical side. So if you're interested in surgery, he's really your man to go to as far as how to do it free market-wise. I'm curious, how many people are familiar with the Surgery Center of Oklahoma? Assuming the vast majority of people. Okay, cool. So of course, what they do is post their prices online. They're very transparent. They don't work with insurance companies anymore. They work directly with either patients through direct pay or through self-funded insurance programs via the employer. So my paper really focused on the fact that our solutions in healthcare, how we drive down cost and thereby increasing access, because of course you want to give everybody access, how do you do that, really bring down cost? So the paper was about the fact that there's proof of concept via the Surgery Center of Oklahoma and direct primary care. And that by essentially embracing these two models, you can allow healthcare to move forward, provide quality care, high access, low cost. So the paper just really centered around that. And at the end, I touched on really one issue, at least from the surgical side in the ambulatory surgery center in the hospitals, when it comes to these free market approaches as Dr. Keith Smith is employing. And that was a provision in Obamacare. So there was something that was kind of snuck in there that a lot of people didn't really know about. I'm pretty sure vast majority of people don't know about. I didn't know about it until recently. This provision specifically, and so I'm going to quote something from a guy by the name of Craig Conway, who's a lawyer. I think this is a Cornell publication. And he specifically says, quote, "The provision remained in the legislation, that being the ACA, and as a result, the Patient Protection and Affordable Care Act prohibits future physician investment in hospitals and caps existing physician investment in hospitals." So this makes it very difficult for physicians to essentially be invested in the hospital that they're performing surgeries at, similar to what's going on with the Surgery Center of Oklahoma. So of course that's an issue, and that would have to be something that needs to be attacked to really allow that market to open up. So the other thing I wanted to touch on is the fact that this article that I wrote was an extremely popular article on the Daily Signal. I kind of looked through, and it had more Facebook likes, more tweets than any other article they'd done in healthcare in quite a while. And I think that the reason for this was because it was solutions driven and it was innovative based. You know, it wasn't talking about a problem, hey, here's the problem, and basically government just needs to step out the way. It was very solutions oriented. I just think that speaks to the fact that everybody's always very open to hearing about solutions regardless of your political ideology, and they're always very open to hearing about innovation. So I just see that as an easy way to bring other people in. And then of course, as I mentioned earlier, as you bring those people in and they say, wow, that's a great model, we can provide good quality care at a low cost to a great number of people, they start to realize, hey, well actually that can't occur if this regulation or this exists, and so you kind of get to the policy kind of through the back door in a way there. So that's essentially it. You guys have any questions? Danny?
Are there any legislative proposals trying to ameliorate this right now?
Not that I know of. I don't even really think it's known. I mean, most people don't even know about it. Samir?
Does this prohibition on physician investment in hospitals extend to all hospitals or only those that take Medicare?
I can't speak to that. The article didn't touch on that. That would require a little bit further research. It gave me the impression that it was broad over all hospitals. It has to do with, it's just Medicare. It has a lot to do with the Stark Law, I know. And it essentially, it modifies, I know, in a current existing Stark Law, essentially. So basically, if you continue on with the article, it basically says, in effect, the provision significantly restricts an exemption to the Stark Law prohibiting physician ownership in what's called whole hospitals, known as the whole hospital exemption.
Yeah, it's a problem because if you accept Medicare and you are a physician-owned hospital, you can't expand or you lose your, so any existing physician-owned hospitals are grandfathered in, except if they expand, they will lose their Medicare contract. And any new physician-owned hospitals cannot contract with Medicare. And if you think about where most hospitals get their sickest patients and people who are paying for that, it's Medicare. So it pretty much shuts down these physician-owned hospitals. They were considered specialty hospitals. The general hospitals were threatened by them. That's why that prohibition was put into the ACA as a way of really buying off big hospitals to go along with the ACA.
Well, I was going to also mention, I think that presents an obstacle in the sense that a lot of these surgery centers, there's one known as the Monticello Surgery Center in Charlottesville, Virginia, and I think Dr. Smith's Surgery Center, they all started at some point accepting other third payers in a way, whether it be Medicare or insurance, and kind of transitioned into these more actual true free market models. And it seems like it's probably difficult to set up day one unless you have, you know, a massive employer like Walmart behind you, providing you with patients, and start a surgery center of that sort. So it seems like a transition process would be necessary, and I guess that would that would inhibit that.
Between ambulatory surgery centers
In
and
hospitals, yes.
So it gets complicated.
Any other questions? All right, thank you.
Cool, ready to go? Cool, all right, so I'm going to talk about overdiagnosis, and overdiagnosis is not, this isn't my research or anything, it's not my baby, but as I think Michelle and Mina would attest, it's one of those themes that, at least at Dartmouth at least, it's you hear it everywhere, and that and accountable care organizations, these sort of geographic variation, practice variation. These are one of these things that in all of our classes it comes up in one way or the other. I think a lot of places have stuff like that, like a research idea that was kind of identified at your place, and then it ends up being everywhere in the curriculum. So, but I think I have an interesting thing or two maybe to say about it, and so I thought I'd share that with you today. So I guess to do this in a really lightning fast way, a good way to start might be to talk about the fact that we are really good at finding abnormalities. I mean, our technology, we can find the tiniest little lung nodule and minuscule kidney cysts and the little T1A prostate tumors, and we can find. Our technology is really cool. It's actually the diagnostic technology and imaging capabilities are really good. But the kind of uncomfortable question that arises is, are they really problems? Are they all problems that when we find these things? And as you probably know a whole lot better than I do, because you're all med students and I'm not every cancer, and this, I should step back and say that the overdiagnosis story sort of applies, at least has been best researched with regard to cancer. But not every cellular abnormality, not every cancer is destined to cause harm. This one helps me. This graph, with apologies to Gil Welch, kind of helps me really understand it best. I think if you think of the kind of abnormal cell and right there at the origin, you've got these fast-growing tumors, these fast-growing cancers. Those are really tough. I mean, by the time you even find it, it's really dangerous. There's not a lot of hope there. Those are the tough ones. Those slow ones, they grow a little bit slower. This dotted line is kind of indicates the size at which you start to get symptoms and it starts to actually affect your health. Those are the ones that you have a little bit of hope for. You can maybe you can catch it, but it's not going so fast that there's nothing that you can do about it. But then there's the sort of part of the overdiagnosis story is that there's this whole other slew of cancers that some of them go really slow and they actually never would have caused any problem. And that's important if you're talking about somebody who's 73 and they maybe do they need that surgery, or if they're 85. You've got the really slow ones, you've got non-progressive ones, some even regress. So all that stuff over on the side, you could argue is pseudo disease, and sometimes that's kind of a synonym for overdiagnosis. If you diagnose that and start treating that, especially aggressively, that could be overdiagnosis. So if you're looking for a kind of I love definitions. If you're looking for at least a usable, memorable definition, overdiagnosis, you can think of it as the diagnosis of disease that will never cause symptoms or death during a patient's lifetime. In theory, you would have been just as well off not knowing about it, although I am a proponent of having the knowledge that you have one of these things. And of course, so why is it a problem? Because practically all treatments carry some risk of harm or side effects, and of course, everything involves financial costs. So now that's kind of like in a real nutshell, the overdiagnosis story. My kind of observation is that right now, I think the overdiagnosis concept, idea, story, whatever you want to call it, is approaching maturity in the medical and epidemiological world. But I think it's just a matter of time before we really start seeing it coming to the policy world. In fact, you could say it's, in some ways it's already here. But, and when it does arrive, So the title of that I put on this was, framing overdiagnosis. There's a couple different ways you could think about it, and there's a couple of different ways that it could manifest itself. One could be this sort of argument. This is the one that I fear. It kind of goes like this. Look, we don't have great understanding yet of the benefits and risks of all these treatments, and we don't really know which of those cancers are going to be harmful, which of them are going to be the pseudo disease, and which ones are actually going to be affect our lives. And number two, we don't want to overdiagnose and overtreat because of those harms, the harms and the side effects and the cost of all of it that could be unnecessary. So therefore, let's have a group of experts in Washington to determine what's best on average for the population and make everybody comply. I mean, these are kind of the guidelines that you can see already being developed, like iPad and all the rest of it. But I think there's a different way to still accept the kind of medical reality of overdiagnosis, but think of it maybe in better terms, frame it in a better way for our purposes. And that would be more like this. So the first two are the same. We don't have a great understanding of the benefits and risks of various treatments. We don't want to overdiagnose and overtreat. Therefore, why not have each patient choose in consultation with his or her doctor which treatments and risks make sense for him or her? So it makes it more of a patient-driven, shared decision-making kind of tale. So real briefly, I think, as descriptive medical science and epidemiology, I think the overdiagnosis story, I think it's useful and I think it's real. But I'm concerned that it will be kind of co-opted by the central planners out there, though they might want to use it to, as evidence to, dictate policy with reimbursements, kind of in the name of, like I said, with adhering to evidence-based care. And alternatively, I'd like to see it more become part of the argument for greater patient empowerment, healthcare consumerism, and shared decision-making. And that's kind of it. So I do recommend the book. There's a book out there, Overdiagnosed, and it's pretty good. But I just don't want people to be afraid or kind of reject throw the baby out with the bathwater. I think, like I said, I think the overdiagnosis story is very interesting and compelling, but where we go with it from how it gets implemented on the policy side could be either good or bad. So that's it. Anytime you have a third party involved at all, it's not going to be totally a patient-doctor decision, that'll play into it, but I'll take it. I agree that it's mostly more about the treatment is what, over-treatment, that maybe it should be called that instead. The way that overdiagnosis is defined and kind of explained in the book is that the diagnosis part is you're diagnosing a disease, not just which is more tightly linked to, I guess, the sets you on a course of treatment, I guess, and it's not the like he didn't call it over-identification or something like that, or over-detection. I mean, he didn't call it that. So the wording and the definitions matter. I think they're interesting. About being in an NGO or someplace, or volunteering or something. Yeah, I'm in it for the policy, really, for the policy insights, and the name of the institute that I'm it's a student at Dartmouth is the Dartmouth Institute for Health Policy and Clinical Practice. It really wraps. I think it's broader than just maybe narrow. The kind of stuff that you might be thinking is limited to what you normally think of with public health. We do talk about policy and legislation and all that as part of the curriculum. In the back.
Since I've worked in diagnostics for 15 years, there are two things that hit you once you get out of an academic medical setting. And one is the drive for diagnostics for defensive medicine for the legal reasons, and the drive for diagnostics as a revenue stream to the practice, especially as reimbursements get cut and they try to, there's physician control through monetary inducement or cutting. So you've seen the last few years, surgeons get less, and general practitioners, internists get more. They always, the CMS and it hates practicing and telling you how to practice medicine. So instead they just control the payments and inducements and rules, and it just goes crazy. But if there was a free enterprise system, you could easily have what happens in Florida, where it's okay not to have malpractice, and the patient just signs off, I promise not to see you no matter what, and it actually sticks, and then we don't have all this defensive over-diagnostic. But this is what you face then now that insurance carriers are terrified of that, and then as you get more personalized diagnostics, and labs like mine get into molecular medicine, and we have to make these huge capital investments to do it, you have all these competing forces to try to stop all that. And this is the freight trains running toward each other that you don't really get a taste of until you're out in private practice that really turn things upside down. Just my 2 cents.
Absolutely.
So to answer the question that was posed earlier, I would have chosen a more straightforward title for this talk if it were not going on my CV. So yes, these things like can, do, and should go on your CV. So basically, the goals for the talk today are to highlight some of the teachable moments from the last 3 years doing BRI at a very left-leaning New York City academic medical center, and some of you have heard bits and pieces of this already. Hopefully provide you with the opportunity to compare and contrast this with some of your own experiences. Ideally, you'll identify some strategies for dealing with pushback or opposition, not to your ideas, but to your group or to your presence or to your legitimacy. And if there's time and if there's interest, we can describe how BRI fits into the residency application process, because a few people were concerned about this a couple years ago and then last year, but it seems like less of a concern now. We'll see. So this is sort of going to take the form of a mini retrospective about my time at Sinai. So this is Mount Sinai from the air in the first week of February. That tall, dark building in the middle is the Annenberg building. It is constructed on left-leaning ideology. You can't see the tilt from this angle, but believe me, it is there. So this is the medical school where the year before I came there, the mandatory for first and second year students health policy day was a debate between the diverse viewpoints of PNHP and the Commonwealth Fund. They said, I talked to the organizers, why didn't you get anybody who doesn't like at least Obamacare? And they said, well, the Cato Institute is in DC and too far. There's no one close by. They'd never heard of the Manhattan Institute, which I don't know if you know where Manhattan is, but it's where we are as well in that last picture. So, they just didn't know. When Occupy Wall Street was going on, one of the assistant deans sent out that email, sign up with PNHP to get flu shots to Occupy Wall Street. An assistant dean. The gentleman on the right over there is Mike Burgess, one of the few physicians in the House of Representatives. Went to medical school with the president of the hospital's medical board. Invited him to speak, talk about the sorts of stuff we hear about, just very nonpartisan, just how to get involved with policy and politics, and there were students outside handing out leaflets and protesting because of his positions on abortion, not willing to go in and listen to his talk on something pretty different. Peter Orszag is on the left. He used to be the head of the Office of Management and Budget for Obama. He's on the board at Sinai. He's spoken at a couple of these mandatory health policy days, and a lot of students find him too conservative. Just think, a lot of students find him too conservative. He worked in the Obama administration, but he uses the language of economics, a lot of things like this, like again, student affairs, the Department of Medical Education, very, very left-leaning, a couple of administrators have sort of been very openly hostile to these viewpoints to some of the junior students. So this is where I go to medical school for the next month and a half. So let's talk about tonight. Let's talk back, for the Occupy Wall Street one. Sometimes if things like this happen in your school, I just want to get this out now as a teachable moment. Sometimes this is the best thing to do. Just ask a question, and if they really want to own it, make them own it. I got a very terse one-word reply back from med student admin that just said no. Sorry, so I emailed after after one of the assistant deans sent out we should all come and join her and PNHP in giving flu shots to the Occupy crowd. I just emailed back out of curiosity, is this an official Mount Sinai School of Medicine medical education sponsored event? And they responded no, and they didn't seem very happy that they were responding, but little things like that, it lets them know someone's watching. So how hard have we gotten squashed since we started this BRI chapter, right? And the answer is not a lot. Since we started the chapter, we've had 2 large debates. We put that flyer on the left up. That's an awesome, I'm sorry, thank you to the Cato Institute for letting us use that image. That is an awesome flyer. The topic is on med mal reform, saintly doctors and demonic lawyers in the stained glass style. They put that on the TVs they have on the med school floors where they rotate student flyers. Not a word back from them. We've had smaller events. We did a similar journal club thing that was described earlier with some other groups. The guy on the right is Ovik Roy. He is at the Manhattan Institute, also located like us in Manhattan. So last year's Health Policy Day, the two speakers at this mandatory event were Peter Orzag, who we saw before, and Ovik Roy. And the reason that Ovik Roy was there was because the text is probably too small, but the first-year students who were organizing Health Policy Day on behalf of the school knew that Benjamin Rush was there and knew that they really didn't have an excuse. So they emailed us to ask. And we were able to suggest Ovik Roy, and they brought him in. So, just despite everything I talked about in those first few slides, we've had a decent run, I have to say. The usual challenges of succession and competing for eyeballs, but nobody's really tried to stomp us out. Nobody's really tried to disband us. Not everybody's necessarily happy with what we're saying, but they're usually at least tolerant of the fact that we're saying it. So, a few really quick strategies for success that I want to go over. You want to know your limits. Don't write off your classmates. Be the better group. If you take anything else away from this, be the better group. Keep your friends close, your opponents closer, and you will still match at the end of all of this. Your ideology will not be a barrier. So pick your fights carefully. Those of you who go to public med schools are protected by the First Amendment. That is not necessarily the first thing you want to say when somebody suggests that maybe you shouldn't be having this event. Not everything is worth pissing someone off for. In general, my rule is if they're really going to take down my career, I am taking them down with me, and no one's ever come close, right? Know what the rules allow. Know what other groups have gotten away with before, right? Know what sorts of things do and don't get accepted by the people making the rules. If somebody, tells you maybe this event that you're advertising is too strident, maybe you need to tone it down, never start with your strongest argument back. Because a lot of times what they're anticipating a rebuttal from you, and they're already ready. Whatever you say to them, they're still going to say, no, you still have to. So always start with, a softer, weaker argument, and then when they sort of reflexively say, no, but you still can't, then you start scaling up to the argument that actually has a chance of persuading them. Because it takes time for them to reply to you and deal with all your arguments. So let them feel like they've really tried, and then, so the last point, respect authority, this has worked very well for me, not just with BRI, but for my generally being a shit disturber at this school, right? Respect their authority. When they tell you to do something, do it, but make them tell you to do it. If they really don't want you there, if they really do not want that flyer up, don't let them suggest it, don't let them hint. I appreciate your advice, I think I see what you're getting at, but this happens to be a really great thing that we want to use to communicate. If they're going to exercise their authority to stop you, make them exercise it, make them own it, and then ideally get it in writing and send it to Beth, who will send it out to the donors who will open up their wallets. All right? This is what you do. This is what you do. Know your limits. Don't write off your classmates. So as you can see, if you can read this, I send out the most atrocious publicity emails. It's terrible. I'm shocked I got any responses at all. So I sent out an email, are you fiscally conservative but don't want government making decisions about your body? Do you think healthcare needs less government and more entrepreneurship? Not really a fan of Obamacare. And then I said, there's a group of us with libertarian / conservative / non-liberal views on health and economic policy. If you're one of us, identify yourself. I was expecting a few hate emails. I was kind of hoping for a few hate emails so I could send them to Beth and we could go through that process I described earlier. And in that respect, my classmates actually kind of disappointed me. There were a lot of like-minded students who were just waiting. So there was an older student, I'm in. Good for you guys. I was always too scared to say these things out loud. There are people who are waiting for someone who's been exposed to this group in this room who knows that there is this support, who knows there's this legitimacy. They're waiting. This is why someone was saying yesterday, you want to frame your events maybe in terms of the doctor-patient relationship and innovation, but I don't think you want to hide who you are, because if you share these viewpoints and you're not willing to say that openly, no one else will. And then the other thing is there were a lot of, the really tiny text one, the head of AMSA, oh, I so totally disagree, but very curious to meet the Benjamins, Rushes and otherwise, that you round up, At Sinai, even a lot of the left-leaning students thought that this is too left-leaning for me. They appreciate the perspective, and don't be afraid to reach out. Be the better group. If you read left-leaning stuff on identity politics, you see this. If you're an oppressed minority, you have to be better just to be at the same level. This is true. So you have the resources, though. You have the support from national, the funding. Beth will help you find speakers. Run better events, right? Make your events and your speakers unambiguously better than everybody else in terms of the tone, the quality, the food, if you can pull that off. If you're a little bit worried, start with some safe areas, right? Medical malpractice reform. Nobody regardless of their political leanings in medicine, likes the lawyers. So who out there in the policy arena also doesn't like the lawyers? Well, it's the Manhattan Institute, it's the American Enterprise Institute, it's the conservatives and libertarians that ordinarily people are going to look at and say, oh, I don't want to listen to them. But now they're here talking about how we need tort reform. That gets their attention. That's a safe area. Direct primary care, again, just talking about Dr. Josh and all the awesome things he's able to do for his patients, right? And you can use these safe areas to open people's minds, get the ideas in there, without necessarily encountering that reflexive opposition. We're in a big city. Sometimes at our bigger events, we invite, nearby, we're not part of a large university, so we'd invite law students from other schools, because it was a litigation-related one, so on and so forth. Just don't hesitate to get outside people to fill your seats. It makes your events look better. Find events that suit your school's culture. Ours, Sinai students sort of like serious scholarly because we're a bunch of nerds, but you guys know what works for you, so do that. And sometimes you're not going to persuade people. And if it's a debate, if you're doing a debate, let's say, between you guys and PNHP, you're not necessarily going to persuade the other side, and that's fine. Your goal is to persuade the spectator who doesn't have a view yet, right? And so that's how you need to frame it. Sometimes your goal is just to, I don't know if you're familiar with the concept of the Overton window, but the idea that there's this broad spectrum of opinion, and within that window, that's what people consider legitimate. That's what people consider sane. Sometimes your goal is just to move that window, and if you can do that, that's huge, because it means the next time people hear these ideas, they're going to be looking at them with a bit more respect. And the bottom line is it's hard for anybody to complain about what your group does if you add value. And if anybody says anything, you want to be able to point to the awesome events you did, what you added to the education of your classmates, and say, we've added a lot of value. Really, what's the problem? Keep your friends close. So our school is 140 students per class. I talk about health policy all the time with my classmates. So sometimes a lot of selling these ideas is really just at the risk of sounding like a marketer, leveraging your personal brand. And again, because you're in the minority viewpoint, you need to be at least as good as everybody else to keep up. So, study hard. Don't forget the basic medical school stuff because you're pursuing BRI. You don't want to be the group. Every school has a few student groups that are sort of where all like the problem students hang out. Don't be that group, right? Come to these conferences. We were talking about resources to help you know your stuff. You want to be the person that when somebody else has a question about health policy, they go to you because you'll give them your take. You'll give them the facts. You'll give them a fair version of the other opinions on the subject. You want to do your best to be that person to your classmates. And another thing that just helps protect yourself is add value to your school outside of Benjamin Rush. And this is especially me. I'm a troublemaker. Hopefully not as many of you are. You don't want to just be the Benjamin Rush person if you anticipate trouble. You want to be the student that Student Affairs refers kids to when they're in serious academic difficulty. I'm not Samir from Benjamin Rush alone. I'm that Samir. I'm the Samir who helps with BLS training every year. I'm the Samir who helps them with international student advising. So if it sort of expands the limits, before they're even going to think about giving you a hard time for something, if they know that you're adding value in other ways as well. And this is something that unfortunately you shouldn't have to do to be accepted, but it helps. And this is one of the reasons that your older students are invaluable. If during an event or something this year, someone from the administration or a student was giving anyone a hard time, they know me. I know them. I know what I can get away with. They know who I am. And your older students, keep your fourth years involved. They can really help you deal with any pushback that you get just because they're more established than most of the M1s and M2s. And then Milton, I know I'm running a bit long. I'm sorry. Milton Friedman quote, when you talk about liberty, you have to smile. This is important in every sense of the word. Just be nice when you're debating these things with your classmates. So really quickly, because a lot of people have talked about this, the people who are giving you the most problems are not the AMA, not Doctors for America, not AMSA, not PNHP. It's the students who don't care. And we've had enough talks about working with them just to get people thinking about health policy. And really, you're all on the same page about that. Go to their intro meetings at the beginning of each year. Say hi, introduce yourself. They can't hate you that much if you do that. Make sure they know who you are and offer to help them out with stuff if they do the same. And make it a good relationship just to improve the general educational climate. It doesn't have to be a zero-sum game. Is this a concern for people? This was 2 years ago. I haven't heard anything about it this year. We can skip this. We're running long.
I just want to add one thing. So you not only matched where you want to match, and you also matched at the school that you're leading Benjamin Rush. They know you. Same thing with Bruce Shaver, who is here from GW, and he led Benjamin Rush for several years at GW, and he got into the psychiatry program at GW. Then there's another BRI leader who started as an M1 and was very actively involved out in Colorado for 4 years. He also got matched to the program that he wanted at Colorado. So it's not causing people to have trouble being where they want to get in, even where they really know you well. So I don't think that that's really a concern.
Yeah, no, this was a concern 2 years ago, but I think that's largely been dispelled. So, yeah, that's sort of my spiel. Hopefully there's something useful, or if you knew this all already, which hopefully some of you did, you have a framework in which to present this to the students taking over. So, because again, Sinai is super leftist, but they haven't touched us. Question back.
I was just going to add an experience to reiterate what you said about not, or kind of, what did you say? Not expecting people to be opposed to you and not writing off your fellow students. When we started our chapter, we had tremendous pushback. It went on for like 2 months and it was awful. I had to fulfill all these requirements to be a student org, and one of the requirements was getting 25 signatures. It was easy. All of a sudden, 25 wasn't enough. We hadn't actually fulfilled the requirements that were like on our website. So I said, that's fine. If these 25 people aren't good enough, I'll find 25 others. And I did that, and that was easy. Like, our classmates wanted us on campus, and once they found out what was happening to us, they supported us even more. So, like, seriously, that was one of the biggest regrets I had going through the process, was expecting people to not care or to not support us. Like, your classmates will support you and they will want you on campus.
Yeah, no, that's a great experience to share. I mean, people get scared, and that's understandable. But if you're here, that means that to some extent you've already stepped up, and that's something you can keep doing. And people know when they're getting a one-sided education. Even the ones who agree with it usually don't like it. Any other? Yeah.
I'm just going to add to what you said earlier about adding value to your classmates' lives. I think I found that adding value outside of BRI and outside of anything political or what have you, could be helping them study or help them understanding how to navigate through medical school or whatever, adds a lot of value. And that will then open doors and allow them to be receptive to more things. I've found that to be absolutely true and very productive.
Any other questions? You guys are welcome to email me about Benjamin Rush stuff, policy stuff, residency stuff, life in New York, life in Canada, whatever. My email's there. Use it. Thank you.